Hi, everyone. I'd like to thank SAGES for the opportunity to present. So before I start, quickly, these are my disclosures. There are no conflicts of interest. So basically, as we know, cholelithiasis is a common disease affecting more than 20 million adults in the US alone. Each year, up to 4% of these patients will develop symptoms, and the most common severe complication, as we know, is acute calculous cholecystitis, or ACC. Now, randomized controlled trials, meta-analyses, and expert consensus support the use of early cholecystectomy as optimal management for ACC, as it's been shown to be associated with shorter length of stay, with no differences in postoperative complications or overall morbidity compared to delayed cholecystectomy. Now, the justification for operative management is basically that gallstone-related events are quite common. So this is a table taken from a population-based study in 2013 by de Mestral, showing that in patients who had an initial episode of ACC and were treated without cholecystectomy, 14% of these patients end up developing gallstone-related events within 6 weeks of discharge, and that proportion increases to almost 19% within 12 weeks. So it's quite a high rate. Despite evidence and expert consensus supporting the use of early cholecystectomy, we know that variation in practice remains, with worldwide reported rates of early cholecystectomy ranging between 35 and 75%. And so really the aim of our study was to try to identify variables associated with early cholecystectomy to try to target opportunities to reduce variability in management and promote adherence to best practices. So we conducted a retrospective cohort study. We included adult patients who were admitted with a first episode of ACC to the surgical units at the two main hospital sites within our university network between June 2010 and January 2015. We used the 2013 Tokyo guidelines to determine definitive diagnosis of ACC, as well as severity of presentation. And we used the 2010 joint ASGE SAGES guidelines to determine the risk of concurrent cholelithiasis, which we dichotomized as either low or intermediate high. We excluded patients who had concurrent cholangitis or concurrent biliary pancreatitis, as well as patients who had severe ACC with sepsis or organ system failure. We also excluded patients who were admitted to medical units with other diagnoses, and those who were not assessed initially by a general surgery team. We defined early cholecystectomy as OR during the same admission within 7 days of presentation, and we defined initial non-operative management as admission for ACC treated conservatively with or without eventual cholecystectomy. In terms of outcomes, we collect data regarding patient demographics, clinical presentation, course in hospital, as well as involvement of an acute care surgery team, and whether or not the treating surgical staff performed elective laparoscopic cholecystectomy. Our primary outcome was early cholecystectomy versus initial non-operative management, and our secondary outcomes included time to OR, total length of stay, in-hospital complications and 90-day readmission rates, as well as gallstone-related events after discharge. We used a multiple logistic regression analysis for the primary outcome. So if we look at our results, we included a total of 374 patients with ACC. This is divided by site, but basically what you can see is that there was a total of 246 patients who underwent early cholecystectomy, which is 66% of our cohort. There were 128 patients who had initial non-operative management, and out of those 128, 60 had eventual delayed cholecystectomy, and 68 had no delayed cholecystectomy. If we look at patient characteristics, we can see basically that patients who underwent early cholecystectomy tended to be younger. They also tended to have a lower Charlson comorbidity index. They were also more often assessed at site number 1 and more often assessed by our acute care surgical team. They were also more often managed under a staff who practices elective laparoscopic cholecystectomy. If we look at patient outcomes, we can see very clearly that in terms of time to OR, patients who had early cholecystectomy had a median time to OR of 38 hours, which contrasts 69 days for those out of the non-operative group who ended up having delayed cholecystectomy. In terms of complications during hospitalization, there was no difference there, but what we did see is that in terms of total length of stay, the median length of stay was shorter, as expected, in patients who had early cholecystectomy versus those who had initial non-operative management. And this was mostly driven, once again, as expected, by lower rates of 90-day readmissions and lower rates of gallstone-related events after discharge. In terms of the flow diagram of post-discharge course for patients who are treated initially non-operatively, we can see that out of the 128, basically there were a total of 23 patients who ended up having gallstone-related events. More importantly, out of those who were treated who did not have delayed cholecystectomy, we can see that 19 had gallstone-related events. And really, what's interesting is that in the total, 17 had gallstone-related events within 90 days of discharge. More importantly, out of these 19 patients, 18 ended up requiring emergency admission and emergency cholecystectomy. We can also see that there were 22 patients who either refused OR or were deemed poor operative candidates, and 27 here were lost to follow-up. When we looked more closely at these patients, we saw that compared to the 101 other patients, they did not differ except for the fact that they were more likely to have been admitted under a staff who does not practice elective laparoscopic cholecystectomy. Now, if we look at predictors of early cholecystectomy, we can see that compared to the referent category, of age category, every single other age category was independently associated with a lower odds of early cholecystectomy. Similarly, when we look at comorbidity burden, a CCI of 2 was associated with lower odds of early cholecystectomy. Now, when we look at other factors, patients who underwent early cholecystectomy were patients who had a higher rate of higher risk of concurrent cholelithiasis, or those who were assessed at site number 2 were half as likely to undergo early cholecystectomy compared to other patients. And also we saw that those who were assessed by acute care surgery team were more likely to undergo early cholecystectomy. And so basically what we're able to conclude from this is that there are important patient factors as well as systems or institutional factors that are associated with early cholecystectomy, specifically that lower age, as well as lower risk of concurrent cholelithiasis on presentation, and lower comorbidity burden seem to be associated with early cholecystectomy. From an institutional point of view, we see that site, as well as involvement of an acute care surgery team, seem to be associated with early cholecystectomy. And this is important basically because we know that multiple strategies will be necessary to promote adherence to best practices in the management of ACC, and ultimately to implement change in order to allow for a broader use of early cholecystectomy. Thank you.
The paper's open for comments. One question that I had, it looked like in your early group, the range only went up to about 60 hours. I'm not sure if I saw that right. I know your inclusion criteria was up to 7 days.
Mm-hmm.
What was the latest early cholecystectomy that you guys had? Do you remember?
I believe, well, it was so that was a median. So up to 7 days included 7 days basically. We had, I think, the latest that we had was 7 days after initial presentation. Yeah.
Hi, Prashant Sinha from New York. Good presentation. We actually also observed when we instituted an acute care surgery team, it removed the burden of scheduling from the other surgeons, and we were able to get cholecystectomies as well as other operations done a lot faster. So our data mimics that. One question I wanted to ask, for the patients deemed to be higher risk with higher comorbidities, maybe the elderly, did you adopt a strategy to go for an early percutaneous cholecystostomy tube, or did you initially try a period of antibiotics?
So I think that's part of the variability in management. We see a lot of different things. Some surgeons would rather go with a more conservative approach with antibiotics. I think usually what we tend to see is there'll be a trial of antibiotics, and if there's failure there, we'll go with the cholecystostomy tube, unless obviously the patient presents with sepsis, which is why in this case specifically we excluded patients who were right off the bat non-operative or less operative, less amenable to operative management, and we excluded the grade 3 severe cholecystitis patients.
Great. Thank you very much.
Thank you.